Welcome to this educational video on perinatal mental health. Before we begin, I would like to acknowledge the nurse educators at Lowell General Hospital who generously shared this educational slide deck with us. And now let's begin. Hopefully by the end of this presentation, you will be more comfortable discussing mental health with your perinatal patient. So here are the facts. Mental health conditions are the most common complication of pregnancy and childbirth. Anxiety and/or depression impact 1 in 5 individuals during pregnancy and postpartum. Suicide and overdose combined are the leading cause of maternal mortality. And as you can see from this graphic, we have a crisis on our hands. Maternal mortality in the U.S. far outstrips that of other industrialized nations. When we dive down deeper and look at the data through the lens of race and ethnicity, we can see some disparities, with Black women being over twice as likely to die than white women. What's more disheartening is looking over the past 20 years and seeing that the rates have been rising for all women. And the most frequent underlying cause of pregnancy-related deaths is mental health conditions, far outstripping the things we more commonly think about, like amniotic fluid embolism, infection, hemorrhage, hypertensive disorders. And when we talk about perinatal or maternal mental health conditions, it goes well beyond postpartum depression. We're looking at a 2-year time frame from pregnancy through the first year postpartum. And it also goes beyond just anxiety and depression, but also includes bipolar disorder, obsessive compulsive disorder, post-traumatic stress disorder, substance use disorder, and psychosis. So here's an example of some of the range of maternal mental health conditions. Depression, in which the patient may feel sad, hopeless, worthless. They may lack energy, or they may be very irritable and express anger and rage. Post-traumatic stress disorder, which is often related to a traumatic birth or previous sexual trauma, and may manifest as nightmares, flashbacks, and avoidance. And the patient may want to avoid talking about their birthing experience. Anxiety was when the patient will feel overwhelmed, stressed, panicked. They may be hypervigilant, and they may also express irritability, anger, or rage. Obsessive compulsive disorder, or OCD, involves scary, intrusive thoughts that are often about harm to self or baby, and those thoughts are truly frightening for the mother. Signs and symptoms of these conditions include the following. In terms of relationship with the partner, there may be more conflict. The woman may be emotionally brittle or fragile, or she may avoid her partner altogether. There may be sleep disturbances, such as difficulty falling or staying asleep, or sleeping too much, or having nightmares. Physical symptoms include increased sensitivity to stimuli, headaches, stomachache. There may be issues around the baby, whether it's feeding issues, hypervigilance or avoidance, fear of being alone with the baby, or the feeling that having a baby was a mistake. The patient may have racing thoughts, scary or intrusive thoughts, poor concentration, or just be emotionally off balance. And then people around them may notice personality changes, such as acting out or withdrawing. And the patient herself may feel that the people around her would be better off without me. And so there are two ends of the spectrum. Baby blues, which is very common and benign, versus psychosis, which is the least common, but is a true medical emergency. So, as I said, baby blues is very common, affecting 85% of women postpartum. It's considered a normal transition period that usually resolves without treatment within 2 to 3 weeks and is probably associated with hormonal shifts. Signs and symptoms include emotional sensitivity, weepiness, feeling overwhelmed. The patients will say they cry over nothing. But the other hallmark is that for many times after the woman has had a good cry, she's actually relieved and then able to continue functioning. Psychosis is the least common, affecting 1 to 2 per thousand, but it is a true medical emergency and life-threatening. The onset is often sudden and it can occur within the first 2 weeks postpartum. There is possibly an association with bipolar disorder, and the signs and symptoms include delusions, hallucinations, and a break with reality. And as I said, this is truly a potentially life-threatening emergency with increased risk of harm to the patient or to her baby. So both OCD and psychosis can involve intrusive thoughts, but there's some significant differences. In obsessive compulsive disorder, the woman will have recurring thoughts or visions of things like dropping the baby, letting go of the stroller into traffic, using knives to harm herself or her baby. But these thoughts are what we call ego dystonic. They are inconsistent with what the woman knows to be true, and they are very distressing to her. In psychosis, there may also be intrusive thoughts along the lines of, I can only save my baby by killing him, or there may be religious overtones, believing the baby is the devil, and there may be paranoia. But these thoughts are actually what we call ego syntonic. The woman doesn't feel guilty about having these thoughts because she believes this to be true, and therefore there's a strong desire to act on these thoughts. The people around her may notice bizarre behavior, extreme agitation, or an inability for the patient to sleep. And then the other thing to be aware of is the timing of maternal mental health conditions. Again, we're not talking just postpartum. In one study from 2012, they noted that 27% of patients in their study entered into pregnancy with anxiety or depression. Another 33% developed symptoms during pregnancy, and then 40% developed symptoms following childbirth. Another study from 2019 found that these conditions can last much longer than we typically think. In their study, 25% of individuals who experienced a maternal mental health condition still had depressive symptoms at 3 years postpartum. The peak onset of maternal mental health conditions is typically 3 to 6 months, and the peak incidence of suicide is 9 to 12 months postpartum. And certain parents are at increased risk. So people with a history of mental health conditions, or people who've experienced complicated reproductive experiences like IVF or birth loss. People who've experienced trauma, parents who lack social support, especially from their partner, individuals of color, individuals who face economic challenges, parents with a baby in the NICU, military mothers and spouses, veterans, and immigrant parents. And Black women and birthing people are even more vulnerable. Black mothers are 2 times as likely to experience mental health conditions in pregnancy, but much less likely to get treatment. And this is due to a variety of factors, including being Black in America, chronic stress, bias and racism in the healthcare system, but also social determinants of health and barriers such as time off from work, transportation, and childcare. And it's not surprising that these conditions manifest when they do, because it's almost a perfect storm in the perinatal period. There are hormonal changes that are happening in pregnancy and after childbirth. Sleep deprivation is a large part of parenting young babies. Parents are often undergoing the single biggest identity transition in their lives. And they may have unrealistic expectations around childbirth or what parenting is going to be like. They may have experienced difficulties in the pregnancy or in the time of birth. And they may also have a predisposition already for depression, anxiety that is exacerbated by the sleep deprivation and the change in their identity and their unrealistic expectations or difficulties that they had. And then there may also be lack of access to health care. And the toll of untreated mental health conditions affects not just the women, but their partners and their babies. So women with untreated maternal mental health conditions are more likely to not manage their own health, to have poor nutrition, to turn to substances such as alcohol, tobacco, or drugs for relief. They may be more vulnerable to physical, emotional, or sexual abuse. They may be less responsive to their baby's cues. They may have fewer positive interactions with their baby, They may experience breastfeeding challenges more so than average, and they will question their competence as mothers. Children born to mothers with untreated mental health conditions during pregnancy or after birth are at higher risk for low birth weight or microcephaly and preterm birth. They may have longer stays in the NICU. They may have excessive crying. There may be impaired parent-child interactions, behavioral, cognitive, and emotional delays, and adverse childhood experiences or ACEs, which we know can be the root of some post-traumatic stress disorder later in life. And untreated mental health conditions also impact the partner. Maternal depression is the #1 predictor of paternal depression. 1 in 10 fathers will experience anxiety or depression. And men may manifest this self a little differently with anger, frustration, or stern discipline. And even non-birthing parents may be impacted, such as adoptive parents. Depressed parents are more likely to overuse the healthcare system and less likely to adhere to safety guidelines for safe infant sleep and car seat usage. And then there may be an impact on infant feeding. While breastfeeding has been shown to be protective against certain mental health conditions, for a woman who's already experiencing a mental health condition, breastfeeding challenges can lead to and exacerbate their anxiety and depression, especially if the expectations do not match reality. Women with anxiety and depression may fixate on how much or how often the baby is feeding. However, there is good news with all of this. Maternal mental health conditions are often temporary and treatable. It's key that pregnant and postpartum people engage with the healthcare system. Parents, families, and babies can recover, and there are evidence-based prevention and treatment options ranging from medication to lifestyle changes to counseling to group therapy. And there are resources out there for providers and parents to help optimize outcomes. So one of the keys is mothering the mother. New mothers must recover from the physical and emotional challenges of pregnancy, labor, and delivery, and this takes time and support. So empowering women to seek time for self-care is critical. Sleep is often an issue in the postpartum period, but if a woman can get 4 to 5 hours of uninterrupted sleep, this can make a huge difference in terms of her vulnerability to mental health conditions. Movement is important, light exercise and getting outdoors. It's important to encourage the woman to remember to eat. Eat every time the baby eats, drink plenty of water, and eat a diet high in protein. And then finding ways to get time off. Anyone who's had a child knows that keeping a baby alive 24/7 is a very challenging job, and people need time off in order to be able to continue doing it. And this leads us to the critical importance of social support. That support may come from friends and family, support groups, home visitors, doulas, lactation consultants, but it is important for the woman to have some kind of village around her, to let her know that she's valued and create a warm, nurturing, caring environment and encourage her. Women also need a sense of companionship, to a sense of belonging. They need to know that they're not alone. It's important that she have access to information, guidance and suggestions, information and resources, or that people share their own experiences and give her the time and space to share her experience and process it. And then tangible help, preparing meals, watching children, running errands, folding laundry, all of these are invaluable in the postpartum period. So talking points for when you're doing your education with your patient. So we talk about the 5 R's of patient screening and education. Right time, start the conversation at a time when your patients are relaxed and receptive, not while they're trying to dash out the door. The right tool, it's important to use a validated Edinburgh tool for the screening, and then to use the PSI handouts and Meditech postpartum depression for your education. The right audience. So it's key to include the family and partners in education, since they may help to recognize symptoms before the woman's even aware of them. Right language. So it is important to use a validated Edinburgh in the patient's own language. And we actually have a notebook on MBU with validated Edinburghs in a variety of languages. When doing teaching, it is key to use an interpreter in the patient's language. And then right literacy level. If your patient cannot read, you can still review the Edinburgh with them in their language using an interpreter and record their results. When doing education, you may use teaching sheets, but perhaps instead pictures or videos. Still give the handouts if there are other family members who can read and share that information with the patient. So, teaching points that we'd like every patient to remember when they leave our unit. One, symptoms of baby blues versus more serious conditions. When does it go beyond the baby blues into a condition that requires some help? It's important for partners and families to be empowered to speak up or seek help if they notice symptoms. So again, sharing the resources and the hotline numbers with the partners and family. When to seek emergency help, just as we educate women about the warning signs in terms of hypertension, stroke, PE, they also need to know the symptoms of psychosis that should prompt them to call 911 or seek emergency help. Self-care, empowering parents to ask for help, helping them think about what are their resources that they can count on to help them. And then recognizing the importance of nutrition, sleep, fresh air, breaks, and social support. And then finally, making sure that our patients have the resources through PSI, so the website that's available in 5 different languages, or helping them actually download the Connect to PSI app on their phone, which is available in English and Spanish. Our patients need to know that postpartum mental health conditions are common but very treatable, and that no one should suffer in silence or shame. And now we're going to do a few final slides about trauma-informed care. This is not meant to take the place of training in trauma-informed care, and we encourage everyone to get more training in this important area. But this is also an important part of providing care for our patients with mental health issues. So trauma-informed care is based on the idea of changing the conversation from what is wrong with the patient to what happened to the patient. And when we think about it, there are 3 E's in conceptualizing trauma: events, experience, and effects. So 2 people may live through the same event, but they might experience it very differently. For one person, they may experience it as a traumatic event, and another person might not. The effects of trauma may also vary. So 2 people may experience an event as traumatic, but the way in which that trauma manifests itself in terms of their behaviors may be very different. And some people may have effects or behaviors, patterns of behavior related to trauma without even realizing the source. And us as caretakers may not learn the actual event or experience, but recognize the fact that there is something here that was traumatic in the patient's past. So recognizing trauma, the symptoms, behaviors, or effects you may see. So this includes emotional, behavioral, and physical health problems, such as depression, pain, anxiety. Patients may be irritable, and their behaviors may be perceived as rude or hostile. Non-compliance with care, which includes no-shows or not following up on treatments, or seeming not to pay attention when you're talking to them. Overly demanding, or they may be perceived as indulging in self-sabotaging behaviors, such as substance abuse. And then finally, withdrawal or dissociation. Particularly when a patient is triggered, they may actually dissociate and separate from the reality around them. All in all, they may present as the, quote, difficult patient. And so one of the interesting things to think about is when we encounter a difficult patient, one might wonder, I wonder if these behaviors are trauma-based. And so the trauma-informed approach to care includes 4 R's. One is realize the wide impact of trauma, especially in the perinatal period. 2, recognize the signs and symptoms of trauma. 3, respond, integrate this knowledge into practice. So we talk about universal precautions, approaching all of our patients with the assumption that they may or may not have had a previously traumatic experience. So we're going to provide trauma-informed care for all of them. Being aware of trauma risk factors, such as a history of birth trauma, immigration, substance use disorder, experience with the DCF system, either in childhood or as an adult. Resisting re-traumatization, so identifying elements in care that could be triggering. For example, balancing medical education with the risk of multiple interviews or exams. Being aware of routine practices that might be triggering, such as breastfeeding, vaginal exams, or even something as simple as sitting on a patient's bed. So, the overall principles of trauma informed care are safety, choice, collaboration, trustworthiness, and empowerment. Trauma often involves a loss of control, and it is critically important that we give that control back to our patients. So, safety means ensuring physical and emotional safety. Choice, giving them choices and giving them back control of their care. Giving them clear and appropriate messages about their rights and responsibilities. Collaboration, so making decisions with the individual and sharing power. Trustworthiness, so again, having consistent, respectful boundaries are very important, and consistency in terms of the care and the treatment plan. And then empowerment, so that's prioritizing empowerment and skill building. So providing an atmosphere that allows individuals to feel validated and affirmed with each and every contact that they have with the healthcare system. In terms of perinatal care, birth planning can be a really helpful tool in providing trauma-informed care. So from a safety point of view, this includes who can examine the patient, making sure to obtain consent, and respecting the patient's modesty. In terms of choice, understanding and advocating for the patient's birth preferences. Collaboration, so discussing any interventions before they take place, giving the patient plenty of opportunities to ask questions, and giving them choices whenever is possible. Trustworthiness, so getting all the clinicians on the same page to minimize change in plan, and also helping to set realistic expectations. While on one hand, we do want to help the patient express their needs and preferences, it's also helpful for them to have realistic expectations and understand that in some situations, their choices may not be able to be followed due to medical concerns. And then empowerment, highlighting their strengths and focusing on positive coping skills. So this concludes this presentation, and I do want to thank my colleagues at Tufts Medical Center, Dr. Mergler, Burton, and Hostage, who did amazing work on trauma-informed care and to whom I owe gratitude for some of these slides. I'd like to also acknowledge the doctors at Brigham and Women's who presented on trauma-informed care and were generous enough to share their slides with us. And a big thank you again to the nurse educators at Lowell General Hospital for sharing their presentation on perinatal mental health conditions. Thank you so much for your attention.